Good day, everyone. I hope everybody is doing okay. And I'm here to give this lecture to you so that you can have your freedom to view it anytime you want, because I believe not everybody's still having a good internet connection after the struck of the typhoon. So I opted to record this lecture about the spine assessment, so that you can view it anytime you want before you answer the examination. So let us begin with the spine. At the end of the session, the student would be able to ask pertinent questions relevant to the patient's history, apply the concept of the plumb line upon observation of different segments of the spine, theoretically measure the range of motion of the different spinal segments with the use of goniometer and tape measure, whichever is applicable, assess the muscle strength of each segment of the spine, apply clinical decision making in referring patients to appropriate healthcare professionals, and lastly, create a hypothetical intervention using the concept of upper and lower crust syndrome. So let's begin. So let me just recall to you how you ask the pertinent questions to your patients specific to the spine. So I have here bullets of the different or the highlights of the questioning whenever you are given a patient with having spinal problems. So this is just an overview, a review as well of the questioning, because I believe we encompassed almost the entire way of questioning last lecture that I did. So first and foremost, the chief complaint of the patient. Obviously, you need to ask the patient if what's the primary reason why he came to you, why he sought physical therapy, why he or she needs to be alleviated from the discomfort or pain that he or she is feeling. And again, just a reminder, the chief complaint should always be what? How many chief complaints do a patient usually present? There's only one chief complaint. So if ever you are asking the patient, the most debilitating for them is usually what they complained about. So that's your chief complaint, one chief complaint, and that's it. The others could just be complications or minor signs and symptoms that the patient usually complain of. Next, specific symptom locations such as pain and tingling. And if it's pain, again, we always use this method, or the PQRST method. P, again, just a recall. P is simply, when is it provocative, as well as palliative. When does the pain disappear? What position provokes the pain? What position alleviates the pain? So that's for P. Quality of pain, most especially if we talk about the spine. Quality of pain usually it's like tingling. It's here. Tingling, shooting, sharp shooting. If you can recall my lecture last time, if you talk about shooting or sharp shooting pain, usually it's the nerve root or the nerves that are affected, most especially tingling. And if we pertain to spinal complaints, usually you'll have tingling, shooting, sharp shooting pain, because the nerves are most likely affected. Okay, region. So it will depend on which specific region of the body. So if there's tingling or pain in the upper extremity, most probably the cervical region. The cervical region is affected, and it's simply just radiated to the arms, because that's the closest body segment to the cervical region or the neck region, cervical spine. Okay, then if it's manifesting in the lower extremity, it's starting from the low back or in the lumbar. The lumbar region is the region wherein manifestation would be presented in the buttocks, in the back of the thigh, in the leg, most to the extent up to the foot. Okay, then severity. Last time we talked about how we record the pain, because again it should be measurable. So how do we measure it? Using your numeric pain scale, NPS. So from 0 to 10, that's one way of measuring the pain scale of the patient. 0, no pain. 10, most pain that the patient felt or experienced. So that's it. And for T, timing. When does it occur? During the time of the day. Is it severe in the morning? Is it severe or alleviated in the evening? Because it's very important to, again, determine if the diagnosis of the patient could be determined if ever we know the timing of the pain or the manifestations of the pain from your patient. Next, radiation of pain. This is what I talked about earlier, that if ever there's problem with the neck, the cervical spine, if there's a nerve that is affected on the cervical region, then manifestation would be in your upper extremity. That includes your shoulder, elbow, wrist, and hand. There could either be a weakness if it's a motor nerve, or there could be tingling if it's a sensory nerve that is affected. But most likely, it's the combination of two, motor and sensory. So we should watch out for that. And when you say radiating pain, it starts from one region, then it goes to a different region. It seems like it's traveling from one point to another. That's radiating pain or radiation of pain. Referred pain is somehow similar, but referred pain most likely pertains to visceral in origin. So what do you mean by visceral again? So when you say visceral, these are your internal organs, right? Your internal organs, if they are damaged, or if there's problem with your stomach, if there's problem with your heart, usually it will manifest on the different body parts that are near the heart. For example, if there's problem with the heart, let's say myocardial infarction or MI, and then the patient is feeling angina or chest pain. This is chest pain. Then referred pain most probably would be where? In the location of the heart. So it's most likely on the left side, left ulnar border of the forearm and arm. So in that region, if you are to differentially diagnose the patient, there could be problems with ulnar nerve, because the patient is complaining in that region, in the ulnar region, right? However, if the pain cannot be alleviated by anything, then that's the time that we can recognize that the pain is already a red flag. So we can refer the patient to your physician or to any appropriate healthcare professional. So with careful assessment and evaluation with your patient, you can assess and you can determine that the patient really needs to be referred to a specialist, not just be treated immediately. So that's the beauty and importance of assessment. Okay, and MOI, or mechanism of injury. So if it's a musculoskeletal in origin, obviously, the specific mechanism should be determined by you. You should ask the patient, what happened when you slipped on the floor? What region of the body hit the ground? Is it the buttock region? What was your position when you fell, when you hit the ground? Were you in supine? Were you just sitting down or whatnot? Those kinds of things should be asked to your patient, because if not, there would be difficulty for you to determine what probably is the diagnosis of the patient. But most likely, work-related is associated with spinal injuries, because the spine again is the one that carries the weight of the entire body, the skeletal structure. So whenever you are carrying heavy loads, then there would be affectation, especially if it's chronic or have been prolonged. Okay, meaning it has been there, or you have been doing that thing for a long time already. So mechanism of injury is important. So what happened to the patient before he got the injury or before he got the manifestations? Okay, and how long the symptoms have been experienced. So it's somehow related, because conditions may manifest as acute or chronic. So if you determine that the condition is chronic, then maybe the patient has been exposed to a particular mechanism of injury several years before, but then because of repetitive action, the patient has been doing that during the years that he is performing his occupation. Then we can say that these conditions are most likely your differential diagnosis. You can associate it with that. But if it's acute, it's sudden, immediate performance of an action led to the manifestation of pain or tingling to your patient. So by that, we can say that the condition has just started, not just it's not like it's been there, but it's not like been there for a long time, but rather it's acute. It's just right now or at the moment of the injury. Okay. Next, this is a red flag. Okay, whenever the patient experience dizziness, loss of balance, and fainting, that most probably there's affectation of especially if there's fainting, there could be loss of blood supply to the brain. So for your third year classes, you have a special test for that to determine if there's loss of blood supply to the brain. We call that one your vertebral artery test. But I don't want you to dwell on that right now, but I just want you to give a heads up that you can perform that one. If the patient becomes dizzy and then there's fainting, then probably there's a diminished blood supply going to the brain. So that's why certain contraindications should be noted, and do not do that to your patient. Okay, so if the patient has this vertebral artery insufficiency, you're not allowed to do this exercises to your patient and whatnot. Okay, so this is a red flag. It's just a thing that you need to note because this is very important. Because if there's loss of balance, there could be more injury to the patient if it resulted to falls. Okay. Then, the highlight for this slide are these two terminologies. I believe this is the first time you heard of centralization and peripheralization. Okay, so this is just a basic concept of these two. Okay, so one of these two is simply meaning that the pain is somehow contained. Okay, so when it is somehow related to your radiation of pain or radiating pain. Okay, so whenever a patient performs a certain action, then the pain diminishes. We can call that one as peripheralization. For example, the patient has injury. You've seen the patient's X-ray or MRI. Then there is L4 nerve root impingement. This is just an example. Okay. Then, let's say for example, the patient performed hip flexion. Hip flexion will somehow alleviate the pressure that is on the impinged nerve. So if there is no pressure, then the pain will not radiate. Okay, so it will stay in that area in the L4 region. So we call that one your centralization. Peripheralization, on the other hand, happens if the patient performs the opposite of hip flexion, which is your extension. Hip extension will then be causing the pain to radiate to your buttocks, your thigh, the back of the leg, and to the extent if it's the sciatic nerve or the tibial nerve, it could manifest in the sole of the foot. So that's it for your centralization and peripheralization. So to cut it short, when you say centralization, it centralizes the pain or the symptoms of the patient. It just stays in one area. Okay? If a patient performs an action that causes the pain to travel from one point to another, then we call that one your peripheralization. It goes to the periphery, from the term periphery. Here, periphery. Okay? So it means that the condition is worsening, so do not do that action. If it centralizes, then we can say that the patient is relieving from the discomfort that he or she is feeling. Okay, so those are the basic concept of asking the pertinent questions to your patient. Now let's go over to the observation. Okay, for the observation, I believe in kines, you are taught about the plumb line, right? It's just a line like this one here. In this third picture, there's a line, right? Also in the first picture here, there's a line. So the plumb line simply is an imaginary line that goes through the body, just like this one. And on the cervical region, let's focus from here, this area only, right? Okay, for the cervical region, you also start from top to bottom. Okay, that includes the head. So since it's interconnected, your neck or the cervical region is connected with your head, then this is also the right time to observe the patient's head. If you can remember my like one of my slides before, there's a patient having torticollis, right? So torticollis is observed simply by looking at the patient. So if there is any deviation or asymmetry on your patient's cervical region, when you are looking the patient and telling your patient to relax, then it's either the head is rotated towards the right or to the left, and then there could be lateral flexion over here. So you should note that one in observation, that the head is tilted or rotated to the right, tilted to the left, something like that. And then you also need to check on different regions, or rather planes: anterior, posterior, and lateral. So in the anterior portion, that includes already observing the patient's facial expression, deviation from the normal, and somehow they are just related with your posterior region because they are on the same plane, only that you are viewing it on the opposite side. What makes it interesting for the spine is that the lateral view of the spine can somehow reveal different abnormalities or deformities. Okay, so that's why lateral view could create or could somehow give you ideas on what's the problem with your patient. So like this, sorry. So for the lateral view in the third picture, what you need to see is what? The lordosis of the cervical spine. Okay, lordosis, one of the secondary curves, right? One of the regions that has the secondary curve. Okay, your lumbar and your cervical. Okay, so for your cervical, you should check for lordosis, because if there is too much lordosis, the head could be pushed forward. Okay, the head could be pushed forward, and it will what? Imply that there is some weakness and tightness. If you can see even your classmates or even if your relatives right now at your home, look at their side view. Are they forward headed in posture, or do they have a straight and normal lordosis? Okay, right here in this patient, this picture here, it has a normal lordosis. The patient is not forward headed, so we can consider this one as a normal patient. Okay, but I don't have a picture here for forward head posture, but I believe you can imagine it. Just imagine the head is forward and then there's increased lordosis here. Okay, so that will imply weakness. That's why I included here the upper and lower crossed syndromes, because this is very important. By simply looking at your patient, you would determine what's weak, what is the problem with your patient. So on the next slide, I have written this myself. I have here, it's just a summary of how you determine the upper and lower crossed syndrome. So just imagine this. The patient is standing. This is the anterior portion. This is the posterior. Patient is standing here. This is the head, the neck. Okay, something like that. Let me just erase this. Sorry. Okay. So, something like this. When you say upper and lower crossed syndrome, the concept of this is that if a region is weak, opposite that region, lower, is also weak. Okay? So we can also imply that if the region is weak here, on this portion, what is adjacent to it is tight. Also, the tightness here, it crosses to the opposite side, there will also be tightness in that region. So it will happen in your upper back and in your lower back. And the good thing is, this is what I always tell my students, even before when I was still handling kines, that our body is like a chain. It's connected from one point to another. So what happens on top, it will cascade downwards. Okay? So for in terms of upper and lower cross syndrome, the most important thing for me when I'm looking at the patient, I always look at the lumbar region first. So usually I start in this region when I'm assessing a patient. Okay, I look at the abdominals. If the abdominal muscles are what? If the abdominal muscles are weak, what or how do they look like, or what do they look like, diba? They have protruded abdomen. So if you check an individual having a protruded abdomen, a big belly, automatic, the low back extensors are tight. So there is what? Increased lordosis here. Increased lordosis. Okay, so if, as mentioned before, if you have increased lordosis, we can imply that it is also equal to tightness. Because the muscles are contracting, they are tight. So that's why it manifests as an increased lordosis. So with this concept of upper cross syndrome, if there is something that is tight here, automatic on the opposite side and downward, the hip flexors are also tight. And if you go along for assessment of the hip region, you would know how to assess a tight hip flexor. Okay, by just ocular inspection, the hip region is slightly flexed. That will imply that there is tightness of the hip flexors or iliopsoas. Okay, let's go back to the abdominals. So if there is protrusion of the abdomen, we can imply that there is inadequate strength of your abdominal muscle. Thus, we can consider that one weak. The abdominal muscles are weak, and on the opposite side and down, crossing the midline of the body, the gluteus maximus or hip extensors are also weak. So, the buttocks are weak. The buttocks of that person is weak. Okay, so this is most likely the lower crossed syndrome. But again, because our body is like a chain, it will cascade up and downward. Okay, so if this is weak here, the gluteus maximus, your quadriceps femoris are also weak. Weak knee extensors. It will also be the same on the opposite side. Iliopsoas or hip flexors are tight. Your hamstrings are tight. Okay, that's going down. Going up, it's the same. Since there's tightness here, low back extensors are tight, your pectorals are tight. Pectoral muscles are your pectoralis major and minor muscles, okay? So we can also say that this individual or that person having a lower crossed syndrome will also have upper crossed syndrome later on if it's not corrected. Okay, because again, our body is like a chain. What happens down, it will go up and it will also go further down. Okay, so it's like that. So opposite to the pectorals, your upper traps and levator scapulae muscles are also tight. So it's just that concept. What happens on this region here, it also happens on the opposite and upper. Okay, same like this. So it's tight, tight. There's also weakness here, weakness of these muscles. Okay, let's go further upward in your neck, and then the neck for cervical, and then capital region. Okay, for capital region, it's the same. Most likely here, this muscle is tight. Rectus capitis posterior major and minor. If ever you have a patient complaining of headache, then you notice that the patient has forward head posture, and you can imply that probably your rectus capitis posterior major and minor are the ones that are tight. Okay, so what? If there's tightness, automatic, you have already an intervention at the back of your mind. What did I tell you before? If there is tightness, muscle is contracting. If it's contracting, you need to relax it. Relax it through stretching. So this is an example of having an intervention or management for your patient manifesting this condition. If there's weakness, for example, weakness of the abdominal muscles, the muscles are not contracting, you should what? Should you relax it further? Because if it's relaxed, then it could be weaker. So what should you do? You facilitate. How do you facilitate? To facilitate this muscle, you can perform abdominal exercises or sit-ups. Sit-ups can somehow increase the tone of your abdominal. So that will also help in reducing the size of your abdomen. I believe some of you are gymmers here. You know that concept. But if you do sit-ups, it could somehow tone down your abdomen. So it's simply just strengthening. So in weakness, you strengthen. If tightness, you stretch. So at the back of your mind, you always think of that. Oh, this muscle is tight, I need to stretch. The muscle is weak, I need to strengthen. Because if it's strengthened and it is stretched respectively, then it would correct the imbalance of muscle pull. Okay, so that's already the intervention part. So don't worry much on that. Okay, I hope you got the concept of upper and lower crust syndrome. Now, observation, let's go down, further down the spine. So earlier we had the cervical spine, now for the thoracic. Since they are interconnected to one another, there could also be problems. If you have problems in the cervical, it will also cascade down to your thoracic region, as mentioned, right? But in here, since most body structures are very obvious and also symmetrical, what meaning what's on the left, there's also on the right side, right? So for thoracic, we can still continue on the plumb line and viewing it anteriorly, posteriorly, and laterally. Okay. For anterior and posterior, the highlight for looking in this plane is your what? Alignment of the spine. Because in a diagnosis we call scoliosis, there is what? Imbalance of the alignment. It could either be it's like this, shaped like this, or shaped like that. Okay, so you should check that. For symmetry, check the shoulder region. If one shoulder is higher, probably there is scoliosis to this patient. If the shoulder is higher, automatic, one region on the lower, in the lumbar region or in the pelvic region, the opposite hip is elevated compared to the left hip, right hip rather, in this case. Okay, so we'll deal more on that in the lumbar region. But right now for the thoracic, I want you to check for the alignment and symmetry. Okay, for anterior and posterior. For lateral region, the thoracic region has maintained the primary curve, right? Primary curves is your what? Kyphotic. And say primary curve because during infancy, or during gestation rather, not infancy, when we are still in our mother's womb, we tend to position ourselves in this position, right? C curve. This C curve, when we go older, becomes your kyphotic curve, which is manifested by your thoracic region. That's why your thoracic region maintains, it's one of the segments that maintains that primary curve, because during gestation it's already in C, and then it's already in C, it's still in C when we grow up. Okay, so check for the curve or the kyphotic curve if it's not too much. Okay, if it's too much, if there's, diba, have you seen Hunchback of Notre Dame? Diba, Hunchback, there's increased kyphosis. If there's increased kyphosis, it will affect the cervical. So cervical region will increase lordosis. Forward head posture will then follow. Then upper and lower cross syndrome again. So that's it. So check for kyphosis as well. And then what else? The shoulder region. In the lateral view, check for the shoulder if it's what? Protracted or retracted. If there is what? If there is tightness, then the shoulder will be protracted. It's as if you're hugging someone. That's the position of the shoulder. Okay? It could also affect your breathing because it tightens the chest area. Okay? Retracted, too much retraction also is not good because it will impose other imbalances in the spine. Okay? So just the usual or normal positioning. Okay? If you follow the plumb line, it's like this. It's like that. Okay? It should go through your shoulder. The plumb line should go through the shoulder region. Okay? So for kyphosis, it's like this. But it's kyphotic. Then there will be forward head because of the increased lordosis. Okay, if it's too much, there's what we call your gibbous deformity. Highly angulated back or thoracic region. If a patient is old already and then osteoporotic, then it would manifest as a Dowager's hump. Okay, Dowager's hump occur in osteoporotic patient. Okay, so it either, but most likely it's the elderly will have this one if they don't have enough calcium in their bones. They are osteoporotic, then it will manifest like this. Almost similar to gibbous deformity. Now let's go over for scoliosis. Scoliosis, to define this one, this is the lateral curvature of the spine. So as you can see, posterior view, one shoulder is higher than the other. So this will imply that this shoulder is elevated and this shoulder is somehow depressed a bit. So if this shoulder is elevated, the spine in that region, that's the region wherein the convex portion of the spine is located. Because again, I want to highlight this one because in naming scoliosis, it's always the convex region. Where you can find the convex region, then we can say that's the side of the scoliosis. So in this case, the convex portion is located on the right. We can call this one your right-sided scoliosis or your dextroscoliosis. Okay, if it's on the left side, we call that one your levoscoliosis. Okay, right-sided dextro, left-sided levo, so you won't get confused. Levo, left, something, stare similar, starts with letter L. Then dextro, it has a letter R, so it's on the right side. So just to be easier for you to be familiar. Okay, so if one shoulder is higher, usually it's higher on the convex side, the other shoulder will also be depressed or lowered down. However, the hip is opposite. If there's right shoulder high, the left hip will also be high, and the right hip is low. So that's continuous, right? So I'm already giving you a heads up for the lumbar spine if there is scoliosis. Okay, then what else? You can see this area here, there's a space. It's due to the fact that the concave side exaggerates the spacing here. Okay, now biomechanically, I believe it has already been taught in kines. So there are highlights for biomechanics. When you talk about biomechanics, that's already part of kines. But I just want to highlight that whenever there is a scoliosis, there are things that can be palpated easily at the back. Okay, so for example, if there is right-sided scoliosis, right-sided scoliosis, on the concave side over here, you can palpate the spinous process of the spines that are affected. Okay, spinous process of the spine that is affected. So when you try to palpate, the spinous processes are very palpable in the concave side, and we can imply that it's also rotated opposite. So when the spines are rotated here, or rather, for this picture, let me just erase this. For this picture, it's rotated over here. Then rotation of the vertebral body is also happening on the opposite side. Okay, and there are also other things that happens here, especially the ribs. Okay, on the convex side, or on the right side this time, this is what's happening on the rib. The ribs are pushed posteriorly, and the thoracic cage is narrowed. There's rib hump on that side. Okay, on the concave side, on the left side here, the thoracic cage is wider, but the ribs are pushed anteriorly. Okay, anteriorly. So we call that one your rib bump. Rib hump posterior, rib bump anterior. Okay, so this is on picture B here. This is a special test we call your Adams forward bending test. Forward bending test. It somehow emphasizes the degree of scoliosis. So you can see here, this is the rib hump because of the posterior region. Okay, the rib hump is very obvious for Adams forward bending test. Okay, it's like this. Plumb line. Let me erase everything. Okay, sorry. So the plumb line, as you can see, this one, your gluteal cleft should be in line with this. This is actually your C7 spinous process, or your vertebra prominence. Your vertebral prominence or your C7 spinous process is very palpable. If you try to flex your neck and then you touch the back of your neck, you palpate downward and you can feel there a bone. That's the C7 spinous process. From there, you hang the plumb line, and it should coincide with the gluteal cleft, this one here. Or in layman's term, we call that one your butt crack, right? So, but the more appropriate term is your gluteal cleft. So your gluteal cleft should coincide with the plumb line. If it doesn't coincide with the plumb line, then we can say that opposite to where the gluteal cleft is, the shoulder is higher, and then there is convexity on that side. Okay, so in this case, right side is higher, then we can say that this is still a dextroscoliosis. Okay, so this is how you assess your but it will be still further discussed during your third year. But right now, I want you to have the concept of how these things are done. Okay? So in addition to observation, we also should check for chest deformities. So we have 3 chest deformities here. Okay? This one. First picture, you can see here the chest is somehow protruded like the breast of pigeons. We call this one your pigeon chest, or your pectus carinatum. So it's usually inherent or congenital deformity. Same with your this one, funnel chest, or your pectus excavatum. Okay, so these deformities are congenital, meaning after birth, then it's already there. Okay, you cannot do something. PTs cannot do something to really to help them address these deformities. And lastly, here you might see here that they have different chest. This is the lateral view. They have different chest shapes, right? We call this one your barrel chest. Usually, barrel chest occurs in patients that are smokers. Chronic smokers later on will develop barrel chest because there's what? Hypertrophy of the muscles of expiration. Muscles of expiration includes your abdominal muscles, your internal intercostal muscles. Since they recruit COPD patients or chronic obstructive pulmonary diseases patient, most especially your emphysema, more on this on your second year, will result to barrel chest deformities. Okay, what do you mean by barrel chest? Okay, so usually if we look at the individual lateral view of the individual, diba, this one, the diameter of the chest is usually narrower compared to when the individual is facing you. Okay, just like this one. Let me go back to some slides. Okay, this one. So you can see the chest diameter here is wider compared to the chest diameter on lateral view. So this is what I mean earlier. Okay, so in this case, the chest of this individual is what? For if we have a ratio here, lateral view to AP view, we can say that this is what? 1:2. Meaning, lateral view should be 1, meaning twice. You should double the length or double the diameter of the lateral view. It will equal to 2 in AP view. So your AP view is twice in terms of the diameter. But in barrel chest, your lateral and AP diameter is equal to 2:2, meaning the lateral view will have the same diameter if the patient is facing towards you or in AP view. Okay? Because there's hypertrophy of the muscle, it widens, it enlarges. Okay? To help them expel air. Because in COPD patients, they have difficulty exhalating or expiring air. Okay, more on this in your cardiopulmo in second year. So just a heads up that you will have these kinds of things. Okay, so the good thing about it right now is that you know that barrel chest individuals will have 2:2 lateral and AP diameter. Okay, next, should also check for breathing patterns as well. So for breathing patterns, it's here. So for child, usually they are what? Abdominal breathers. Meaning when you observe them, they breathe most likely in their lower abdomen. In here. For women, they are most likely upper chest breathers. So when they breathe, the rising and falling of their chest are obvious. But for men, they are mid-thoracic and upper mid-thoracic and mid-thoracic breathers. So their upper chest and middle chest, it expands. Okay, for older individuals, it's somehow the same with your child. They are lower abdominal breathers. Okay, so you should observe them because if the woman is what breathing using his belly, then maybe there is difficulty. The patient has difficulty breathing. That's what you can imply here. Okay. So next, so observation for the lumbar region, it's just the same. We have here a plumb line, a anterior, posterior, and then sorry, this is not in line, that one, and then here. Okay, but for the lumbar region, it's the same. Pelvic obliquity, the thing that I mentioned, symmetry as well. Pelvis should not be it should not be asymmetrical. It should be equal in terms of the positioning of the pelvis, just like this one. But if one is elevated, then there could be problems either from above or below. Okay, and the same concept for the lateral view. For the lateral view in here, the lordosis. Lordotic posturing will result to, again, weakness of the abdominals, tightness of the upper back, tightness of the hip flexors, weakness of your gluteals. So if you can observe those kinds of things, you can give management for your patient. Sir, you can either do sit-ups or stretching of the back muscles. So that's how you observe. By just simply looking at your patient, you can already imply what's happening or what's the problem, what's their problem. Okay, let's continue with the range of motion measurement. So we're done with observation, and let's now go over to measurement of range of motion. So before we begin with the range of motion measurement, ROM measurement, I want you to commit to yourself right now that you would be familiarizing the different bony landmarks, okay? Because it's very important for you to know the landmarks, because how would you measure a specific range of motion? How would you measure the range of motion of elbow flexion if you do not know where to locate those landmarks? Okay, so for the cervical segment landmarks, it's here. It's very important. The red dots are the things that you need to be familiar with. So obviously this is the chin, and then below it, over here, there's actually a space here for between the clavicles. We call this one your sternal notch over here, and then the acromion process of the acromion process, or the point of the shoulder, that's in the anterior view. For the posterior view, here, this is your C7. If you palpate again your C7, vertebra prominence, the spinous process, that's the longest spinous process for all in the spinal region. If you palpate it, above that one is your C6. Okay, although it's not easily palpable, but if you start with what? Starting with your C7, and C7 here, below it, this one is your T1, because C6 is not that palpable. C7 is very palpable. If you try to press this area here and go downward, the next thing or the next bone that you can feel is the spinous process of T1. Okay, then here is also your acromion process. Okay, so these things can be seen in your anatomy, in kines as well. So if you know or if you're very familiar with these things, the bony landmarks, obviously you will have no trouble familiarizing the range of motion or the placement of the different parts of the goniometer, right? So if you can recall, the goniometer has what? The fulcrum, and the fulcrum is usually placed on these acromion processes, but not all the time. We also use your proximal arms, proximal and distal arms. We also use rather the different landmarks to place or place correctly the different arms, or the proximal and the distal arms. Okay, so let's start first with your cervical range of motion. So right now, our cervical region can what? This motion here, first motion is flexion. Flexion motion, these are the placement of your goniometer. The fulcrum, it's on the external auditory meatus. It's over here. The hole in your ear, in layman's term. You place the fulcrum there. The proximal arm, or the stationary arm, in other books it's also called the stationary arm. It could either be perpendicular to the ground, or it could be placed over here, parallel to the ground. Okay, so it could either be here, or it could either be here. Distal arm, base of nares. So if this is your nose, the base of nares is this one, this area here. It should be targeting that. Okay, so if you target that area, then we can consider that one a correct alignment already. So earn and feel again, you can only feel this one in passive range of motion, still firm. Okay, so for the rest of the range of motion, this is how we will be tackling the different motions, or the different measurement of motions of the cervical, lumbar, thoracic regions. Okay, so next motion we have is also from the cervical region, although this is already extension. So extension, you're moving the head backward. Okay, the same alignment. That's why, as I said, if you're familiar, you will have no problems getting to know, or memorizing, if you want to memorize the different alignments of the proximal, distal arms, as well as fulcrum. Okay, so still external auditory meatus, either perpendicular or parallel to the ground for the proximal arm, this one. And distal arm, the base of nares still, and feel is still firm because of the stretching of the muscles here. That's one reason. Okay, next, if we have flexion anterior, we also have side flexion or lateral flexion. Lateral flexion, if you can recall the most prominent vertebra or the spinous process in the cervical region, C7, that's the placement of the fulcrum, spinous process of the C7 vertebra. Okay, then the proximal arms. Proximal arms, it should be what? Aligned perpendicular to the ground, in line with what? The spinous processes of the thoracic. Okay, if you can again palpate C7, if you just simply go down and palpate the bones that you can feel, then that's the spinous processes. That's the very first thing that you can palpate. Okay, the distal arm, it's still perpendicular, but what? It should be on the dorsal midline of the head, using the occipital protuberance for reference. This is another bony landmark to consider, the occipital protuberance. If you know where it is, then it will help you, it will guide you that's the region for your distal arm. Okay, then ask the patient to laterally bend this here, then still firm because of the stretching of the muscles. Okay, this is rotation of the cervical region. First, fulcrum over the center of the cranial aspect of the head. So if this is the head, on top, this is the top view, this is the fulcrum, the center of the head. Proximal arm, an imaginary line between the left and right acromial processes. So again, the acromion process divides the tip of the shoulder over here. Just simply make an imaginary line here, targeting both acromion processes. So that's the position of your proximal arm. Then the distal arm, the tip of the nose. Okay, so ask the patient to rotate either on this side towards the right or towards the left. Second picture here. Then you read the reading for this one over here. Okay, and feel firm. Again, as I believe I have mentioned this already from my previous lecture, that most common end feel is firm, but again, you should be sure of the firmness. However, it will determine the end feel will be determined by the body build of the patient. Okay. Next, we're done with the cervical region range of motion. Let us now proceed to the thoracolumbar segments. Okay, so for landmarks, it's over here. Still, we have here the C7 and T1 spinous processes. Simply continue palpating downward. Okay, then you have here your T12, the last thoracic, and then your L1. Okay, the last thoracic segment is your T12, spinous process of T12. And below that one is your L1. Okay, and let's now start from the most bottom part. If you have seen an individual, if you have seen somebody on their back portion, okay, there are two dimples over that region. We call that one your dimple of Venus. Okay, your dimple of Venus is associated with your S2 segment or your second sacral vertebra. Okay, so we can say that if this is your dimple of Venus, in line with the two, this is the sacral or the S2, second sacral vertebra. Above that one is your S1. Okay, obviously, what's before 2 is 1, right? So simply above that one is S1. Above S1 is L5. That's the last lumbar segment. Okay, I hope you can follow the alignment of the spine. That's why you need to know how many cervical vertebra do we have? We have 7 cervical vertebra. Thoracic, we have 12. Lumbar, we have 5 lumbar. Okay, then sacral, they are usually fused to 1 vertebra, but most prominent one is your S2 due to the dimple of Venus. Okay, it should be aligned. The two should be aligned or straight to one another. Okay, just simply above it is your S1. That's how easy you can palpate that. Okay, so be familiar with that. Okay, now for the thoracolumbar, because most likely they are combined in terms of how you measure them. So for thoracolumbar region, first is we mark the spinous processes of T1 to S2. So simply going back from T1 to S2 over here, I'll just erase. Okay, from T1 to S2 using a tape measure. Okay. Okay. Align the tape measure from T1 to S2 and record the distance. So let's say, for example, T1 here, S2 here. You have in inches, no? Let's say this is just a hypothetical measurement. Let's say you have 35 centimeters, or just simply compute it to inches. I don't know. Simply multiply it to, I don't know. Yeah, multiply it by divide it by 2.54. Sorry, if to know inches. Okay, so if you have already aligned the tape measure from the tip of the spinous processes, you can now measure, and then hold the tape measure in place. Then for flexion, this is actually flexion. You should also follow, still pointing to the T1 and S2 vertebra. Okay, so for example, if this is 35 cm during erect standing, and during forward flexion it becomes 45 cm just simply subtract the first measurement from the last measurement. So 45, 35, so we can have 10 cm. So 10 cm of measurement is recorded, and to interpret it for your evaluation, 10 cm is normal. So if your patient can only, or rather during your measurement of the thoracolumbar range of motion in flexion, there's only 5 cm from 35 cm during erect standing, and then it's simply 40 centimeters during forward flexion. Then we can say that there's limitation of motion already, meaning the patient can no longer flex forward. So there could be a problem like your AS. Or what is AS? This is one diagnosis we call your ankylosing spondylitis. Ankylosing spondylitis is the most common. It has the inability to extend, or rather to flex, something like that, or the position of the patient is already flexing position. There could be the patient could have that diagnosis, or there could be problems with herniation, disc herniation. The patient cannot forward flex because there's pain in the lumbar region. Okay, so there are different implications, but you need to be familiar with the diagnosis first. Okay, so that you would know this is the probable diagnosis, differential diagnosis of the case. Okay, so end feel, it's still firm. Okay, there's another way to measure it, is using a ruler. Okay, so as still erect standing position, then allow the patient to bend forward as far as possible in an attempt to touch the floor. Right, I believe you know how you have been trying this one to see if you can touch the floor from standing position. Okay, no stabilization in the pelvis is provided by the examiner, thus allowing the hip motions to occur. This is to simply measure the greatest measurement. Okay, so at the end of the motion, measure the perpendicular distance between the tip of the middle finger over here and then the floor. Okay, so there's no specific range of motion, or rather there's no specific measurement for this one, but I believe this is due to the fact that flexibility is in play in terms of doing this motion, because we can say that if you have tight hip flexors over here, because there is forward bending, you cannot further touch the ground, right? If you can follow me, because this is tight, the patient will complain of pain here, not on the lumbar region. So there are other key factors that will affect this motion. That's why the most appropriate, or rather the most useful one, is the first one, this one, tape measurement. Okay, so for extension, it's somehow the same, but this time around, instead of bending forward, you bend backward, just like the picture here. So still the same from your T1 to S2. S2 is very easily found because of the dimple of Venus. Okay, so still the same, and then mark the difference. So from because I believe, because this is going backward, the measurement would be what? It would be lesser. So just simply measure the higher number to the lower number to get the measurement. Okay, and side flexion next, or lateral flexion. We still use the fulcrum, because this time around we are using your goniometer now. So still the posterior aspect of the spinous process of S2. That's why again you will keep on seeing these different different bony landmarks. So as early as now, you should be familiar with them. Okay, know them by heart, not just through memorization. Okay, so S2, proximal arm perpendicular to the ground, and distal arm posterior aspect of the spinous process of T1. Okay, I sorry, this one is the stationary arm or the proximal arm, and this is the distal arm. Okay, I was confused. I switched it. Okay, so ask the patient to laterally bend or bend to the side, and then move the distal arm, still targeting the T1. Although this is T1 is most likely found here, it should still target the T1 spinous process. Okay, end feel is still firm. Okay, another way or alternative method is using a tape measure. So ask the patient also before that, let them stand erect, relax their fingers, relax their arms as well, and then ask them to bend sideways as far as possible, keeping the back and shoulder against the wall, both feet flat on the ground with the knees extended. This is fully erect position. Okay, then measure from the tip of the middle finger, because the middle finger is the longest finger, from the tip of the middle finger down to the ground or to the floor. Okay, the measurement should be noted. If there is limitation of motion, obviously there will be less measurement. Although the book did not specifically say what's the ideal measurement in terms of using this one, because again, flexibility is in play here. If you have tightness of muscles on one region, then it could affect the spine as well. So that's why the goniometer is highly advised in terms of measuring this. Okay, then thoracolumbar rotation. For rotation, fulcrum is somehow the same earlier for the cervical region, but this is rotation of the thoracolumbar. Okay, over the center of the cranial aspect of the individual's head, still the same as mentioned. Proximal arm, imaginary line between the prominent tubercles of the iliac crest. Since you are measuring the lumbar spine, the iliac crest, you don't know where the iliac crest is, but that's the point of your pelvis. If you palpate the pelvis on the side, you can feel a bone there. That's the iliac crest. So you should be targeting that one from your top view. Okay, so this is here your fulcrum. The iliac crest is positioned on this side here, so it should target, the proximal arm should target the iliac crest. Stationary arm, distal arm rather, imaginary line between the acromion processes. So it's like this. Iliac crest is over here. So when you rotate, the distal arm should go with the acromion process. This one. Then read the measurement over here. And feel firm or hard. It depends on the patient's body build. So if it's skinny or ectomorphic, then there could be what? Harder and feel. Firm for mesomorphic individuals. Okay, then this is the values in terms of degrees and centimeters. Oh yeah, I believe you're confused because of the different values here, but as early as now, I want you to simply focus on one value, which is your this one, AAOS. I think AAOS stands for American Orthopedic, I forgot, surgeon something. So these values are actually the ones we use in terms of our PT practice. Okay, so this is actually in degrees, 45 degrees, as well as this one. Okay, so when you say cervical flexion, normal value is 45 degrees. And so let's now proceed with manual testing, manual muscle strength testing. Okay, so for MMT, just a recap. Grading for MMT starts with 5, 4, 3, 2, and 1. So a disclaimer for this lecture, I did not include here the plus and minus grading, because again, this is subjective to you, and it's your clinical decision making that will somehow guide you to use, if it's rather to grade the strength of the muscle upon your evaluation or assessment. So all you can see here are entire whole numbers 4, 3, 2, 1, and 0, but no plus and minus. Okay, so let's start first with cervical flexion, starting with grade 5 normal and grade 4 good MMT. So I have here different components on how you should perform the testing, starting with the patient position, the therapist's position, the test, what should be done, and most importantly, the instruction to your patient. Because again, the patient comes to you and they do not know your procedures, they do not know what steps should you be doing, but rather you should guide them through giving instructions. Okay, so this is very important. So let's start first with the position of the patient. So for grade 5 and 4, the arms at the sides, then patient is in supine position and head is supported on the table. Therapist position, standing next to the patient's head, hand for resistance is placed over the patient's forehead. You should only be using 2 fingers because if you use the entire palm of your hand to give resistance, the patient wouldn't be able to resist it, and thus there will be false positive result of your reading. Okay, so other hand should be placed on the chest if it needs stabilization, if the trunk is weak. Then the test, it's done by simply asking the patient to flex the neck, lift their head straight up from the table without tucking the chin. This is a weak muscle group. Okay, then most importantly, your instruction to the patient. For the instructions part, make it sure that the patient would be able to understand what they should be doing, because if they cannot understand what they're doing, then they wouldn't be performing at all. So what should you be telling them? So simply tell them this is just by the book. You can do it on your own words, for as long as you can convey the concept or you can convey the gist of the instruction or the test. So simply tell them, lift your head from the table, keep looking at the ceiling, do not lift your shoulders off the table, because if it happens that the shoulders lifted off the table, it could somehow result in a false positive readings as well, because it gives an illusion that the patient can resist the 2-finger resistance, but even though not, but the illusion of lifting the shoulder, the patient can do the resistance or can resist the resistance provided. So when you let them hold it, then that's the time you give the resistance and tell them not to let me or the therapist push the head down. So this is an illustration of it. So 2 finger breadths, or rather 2 fingers are providing the resistance, black arrow here, and then the red arrow is the direction of motion from head flat on the bed going forward. This is flexion without tucking the chin. Then if the patient can resist this one, a strong or a normal strong resistance, it could be graded 5. But if near strong, then it's 4. Okay, so again, a subjective measure of strength for the therapist. If the patient is smaller in body size, then just appropriately apply the resistance, not to the extent of your full strength of the 2 fingers that you are providing as resistance. So let's proceed to 3. So same, but grade 3 is fair. I have a mistake in here, because there should be no resistance for grade 3, and there should be no fingers to be used to apply the resistance, because again if we recall your components of the MMT, we have the range of motion, ROM. This should be full ROM against gravity, and lastly the resistance, right? But this time there should be no resistance for grade 3. No resistance. Again, no resistance for grade 3. This is my mistake. Then the test, it's the same. Instruction, bring your head off the table, keeping your eyes on the ceiling, keep your shoulders completely flat on the table. Okay, so this is it for the picture. Okay, so no resistance as you can see from the picture. Just simply ask the patient to lift their head without lifting their shoulders. If they can do it, then the patient has a grade of 3. Okay, I'll give you a hint, or rather a tip, on how to execute the actual assessment of the MMT. Usually, what therapists do is they first ask the patient to do grade 3. Okay? Why? Because if the patient is capable of doing grade 3, then you start from there. Will I what? If the patient can perform grade 3, the question to yourself is that, will I still continue providing the resistance? Are you getting my point? Because if the patient can do grade 3, then you can assume that, the muscle is graded fair here. So let me try at more challenging position. That's the time you give the resistance. So if the patient can do it, then it will determine you will determine rather if it's grade 4 or grade 5. But if the patient cannot do grade 3, then that's the time you modify for grade 2. Are you getting my point here? So in the clinics, do grade 3 first, then assess the situation, assess the patient. Was the patient able to perform grade 3? Then from there, if it's a yes, then you can increase the resistance to see if the patient has a greater strength in terms of the muscle being tested. If the patient cannot perform grade 3, then you lower your testing procedure. You go one grade lower, so that's grade 2, until such time that you can find the appropriate grade of the muscle. Okay, for grade 2 and 1 for cervical flexion, positioning of the patient: supine with head supported on table, arms at sides, still standing, or standing up at the head of the bed facing the patient. Fingers of both hands, or just the index finger, are placed over the SCM muscle to palpate them during the test, because grade 1 is a palpable contraction as well, and grade 2 simply is cannot really lift the head because it's against gravity. So the test, the patient's head rolls to the side to side, keeping head supported on the table. Roll your head to the side, on the left side, and then to the right side. Okay, so this is it. If the patient can do that, probably the patient has grade 2. If the patient can perform, at least if the patient is rotated to the side, then try to flex that neck, and then can only partially flex it, then there should be grade 2. If only palpable contraction is occurring, then that's grade 1. If the patient cannot even rotate or perform the rotation of the head, then that's grade 0. So there's no contraction of the muscle. Even a palpable contraction, no. So that's grade 0. Okay, 0/5. For extension, prone. This time the patient is in prone position, head off end of the table, arms at the side. So just imagine, I'll have a picture here later on. Position of the therapist: standing next to the patient's head, one hand is placed over the parieto-occipital area for resistance. Okay, so at the back of the head, this is the back of the head already. The other hand is placed below the chin, ready to catch the head if it gives away suddenly during resistance. So again, safety of the patient by having this hand be by readying this hand to catch the head. Test: the patient extends the neck without tilting the chin. Okay, so the instruction of your patient: push up on my hand but keep looking at the floor. Hold it, don't let me push it down. So this is the position of the patient. Your other hand should be placed under the chin, so whenever the patient cannot hold the resistance, then obviously you have your hand here to catch the head, or the head of the patient, to avoid injury. Okay, so safety again, always consider safety of the patient. For grade 3, still fair. Position of the patient, still prone, arms at the sides. Therapist, Still on the I'm standing to the patient's head, next to the patient's head, with one hand supporting or ready to support the forehead. Okay? Test. Patient extends the neck without looking up or tilting the chin. Still instruction. This time around, you don't provide the resistance. Okay? So it's like this. You are preparing to catch the head. That's why your arms are here on the forehead. Then ask the patient to lift their head. So if the patient can do this, then it's a grade of 3/5. For 2, 1, and 0, supine, with head fully supported by the table, arms at the side. Patient at head end of the table, facing the patient. Both hands are placed under the head. Fingers are distal to the occiput at the level of the cervical vertebrae for palpation, because the muscle attachment for for your cervical extensors are located here. So this is where you palpate the muscles. Then simply the patient attempts to extend the neck into the table, but obviously there will be little movement because of the grade of the patient. So try to push your head down on my hands. It's like this. You are holding the patient's head underneath their or at the back of their head while they are in supine position, and ask them to try to push the bed. If you can palpate the muscle contraction, that's grade 1. If none, it's grade 0. Okay? So that's for your cervical extension. Then for rotation. Rotation, patient position, supine with cervical spine in neutral. No, there's no flexion, there is no extension. This is to provide an accurate result or reading for the MMT. So for cervical rotation, 5, 4, and 3 are usually as 1. Okay, then the head is still supported on the table with face turned as far to one side as possible. Sitting is an alternative position for all tests. So the patient can do this test in sitting position. Your position as the therapist should stand at the head of the table facing the patient. Hand resistance is placed over the side of the head above the ear. Okay, patient rotates head to neutral against maximal resistance for grade 5. This is a strong muscle group. Repeat for rotators on the opposite side. Alternatively, have the patient rotate from left side of face on table to right side of face on table. Instruction. Turn your head and face the ceiling. Hold it. Don't let me turn your head back. So in the book, there is no picture for this one. So just imagine trying to resist the head turning of the patient by providing the resistance at above the ear of the patient as they turn. Okay, because this muscle group is a strong muscle group, they can somehow resist maximally. Okay, so for rotation, grade 2, sitting, trunk and head may be supported against high back chair, because we assume here that the patient cannot control their trunk. So it should be supported well. Head posture neutral to again have a good reading and result. Standing directly in front of the patient. Patient tries to rotate head from side to side, keeping the neck in neutral, chin neither down nor up. Turn your head as far to the left as you can. Keep your chin level. Repeat for turn to right. So it's like that. Simply turning the head. Now let's go over to the spine extension, lumbar spine. Okay, so 5 and 4, prone, as you can see here, no. During extension, obviously, to have clearance during the execution of the test, the patient is always in prone position, with hands clasped behind the head. Okay, for in kines, if this has been taught already to you or you have read it already, this position actually increases the weight on that area. So in this case, the weight there's additional weight on the head area, on the cervical and capital region. because the hands are placed at the back. Okay, this will determine if you have a grade 5 or normal range of motion if you can execute it using this position. Okay, good. Yeah, grade 5 or grade 4. Standing, this is your position of the therapist. Standing so as to stabilize the lower extremities just above the ankles if the patient has normal hip strength. Patient extends the lumbar spine until the thorax is raised from the table. The patient can clear the umbilicus or the navel of the table. Then your instruction would be raise your head, shoulders, and chest off the table. Come up as high as you can. So this is a picture of it. See, your hands are clasped at the back of the head. This provides the resistance already. Then the umbilicus should be clearing the table so as to grade it accurately. Okay, so the therapist stabilizes the lower extremities using the weight of both arms placed across the pelvis. You can either put the other arm over here if the patient has hip extension weakness. Okay, if the patient cannot you're just simply isolating, right? So because there's weakness here, there could be what inability to perform this action here. So stabilization is required to isolate the lumbar region from the hip region during this test. Okay, this is an alternate position like this one. Okay, so for thoracic spine extension, patient position prone, still prone for extension, head and upper trunk extending off the table from about the nipple line. Okay, so we'll see a picture later on. Standing so as to stabilize the lower limbs at the ankles. The same with your lumbar. Patient extends thoracic spine to the horizontal. Raise your head, shoulders, and chest to table level. So this is it. So the patient is positioned at the edge of the table, up to the nipple level. Then slight dangling of that region from the nipple up. Then ask the patient to lift their head until such time that their entire body is in line with the table. So this is it for grade 4 and 5 for thoracic spine extension. So this is actually done this way so that we can clearly identify that the region we are testing is the thoracic spine, because at the nipple level, most likely it's the majority of the thoracic region is at that part. Okay, so that's for grade 4. For grade 3, prone with arms at the sides, because again in here you provided resistance using your clasped hands. Okay, but for grade 3 there should be no resistance, so remove it by simply putting the hands or arms at the sides. So the same, standing at side of table, lower extremities are stabilized just above the ankles. Patient extends spine, raising body from the table so that the umbilicus clears the table. Then your instruction would be raise your head, arms, and chest from the table as high as you can. So it's like this. Okay, so earlier your hands are clasped at the back of your head, but this time around it's already at the sides. This is to lessen the resistance on your upper region or in the cervical region. Okay, so lumbar and thoracic spine extension, these tests are identical to grade 3, except that the examiner must palpate the lumbar and thoracic spine extensor muscles. Okay, so just simply palpate the paraspinal muscles. Okay, and it is very difficult to isolate them, so they are usually palpated as a group. Your erector spinae. This is the name of the muscle group, erector spinae. They run from the thoracic down to here, paraspinal, because they are located along or at the sides of the spine. That helps extend the spine. Okay, simply palpating the muscles will determine their grade. If they're not capable of grading it or um, um, moving it against the resistance, okay, or against resistance and gravity. Okay, for trunk flexion, now we are now in flexion position, so you expect that the patient is no longer in one, and most likely they're no longer in the prone position. Okay, so patient position in supine, hands clasped behind the head. Okay, they're clasped behind the head already. It's because, again, still adding resistance to this area. Position of therapist, standing at the side of table at level of the patient's chest, um, to the point that you can assess that the scapula is cleared from the table. Okay, for patient with no other muscle weakness, the therapist does not need to touch the patient. If, however, the patient has weak hip flexors, the examiner should stabilize the pelvis, leaning across the patient on the forearms. Okay, so the test. So simply ask the patient to flex the trunk through the complete range of motion. Curling up is the best appropriate description of this one, until such time that the scapula is already off the table. Okay, so your instructions would include: touch your chin and bring your head, shoulders, and arms off the table, as in a sit-up position. So sitting up with hands at the back of your head, you already can imagine that one. This one. Your scapula are cleared from that table, then we can say that this is already a normal MMT, or manual muscle testing, for your trunk flexion. For trunk flexion grade 4, patient position, supine with arms crossed over the chest. Okay, so as you can see here, from the position of clasping behind the head, we now move the arms crossed over the chest. So the tests, other than the patient's position, so are all aspects of the test is the same for grade 5. So same instruction with your patient, only that the arms are crossing over the chest. So this is the picture of it. So still, the scapula should be clearing the floor or the mat or the table. Okay, so that's for grade 4. For grade 3, okay, this patient should be positioned in supine with arms outstretched in full extension above the plane of the body. So you'll see a picture of that later on. Then same with grade 5, positioning and testing. The patient flexes the trunk until the inferior angles of the scapula are off the table. Okay, position the outstretched arms neutralizes the resistance by bringing the weight of the arms closer to the center of gravity. So this reduces the resistance this way, although grade 3 has no resistance. Okay, so instruction, just simply tell your patient, raise your head, shoulders, and arms off the table. So this is the picture here, as if the patient is trying to reach the toes by simply clearing the back of the patient until such that the inferior angles are not touching the table. Okay, for grade 2, arms at the sides, knees are flexed. Standing at the side of the table for the therapist position, the hand used for palpation is placed at the midline of the thorax, over the linea alba, and 4 fingers of both hands are used to palpate the rectus abdominis muscle. So rectus abdominis, these are your abs. Okay, these are the muscles that you can see on the belly. Okay, when they are hypertrophied. Test and instruction. The examiner tests for grade 2, 1, and 0 in a variety of ways to make certain that muscle contractile activity that may be present is not missed. So it's like this. So ask the patient to attempt to flex the trunk. In this position, it decreases further decreases the resistance of the patient. And if the patient cannot do it, however, the therapist can palpate it, we can grade it as 1. But total no movement of the muscle or the trunk means that there is no grade, or 0 over 5 MMT grade for trunk flexion. Okay, for trunk rotation, position the patient supine, the still hands clasp behind the head. So as you noticed here, if the hands are further from the center of gravity, as mentioned earlier, it increases the resistance. The closer it is to the trunk, then the lesser the resistance. Okay, so this is the concept of why placing the hands at the back of the head demands more strength of the muscle. Okay, position of the therapist, standing at patient's waist level. Okay, then the test. The patient flexes trunk and rotates to one side. This movement is then repeated on the opposite side so that the muscles on both sides can be examined. Okay, so instruction of your patient. Lift your head and shoulders from the table, taking your right elbow towards your left knee. Right elbow towards your left knee. Then, lift your head and shoulders from the table, taking your left elbow towards your right knee. So it's just the opposite. Okay. So, it's like this. See? So, from this position, the patient is moving the right shoulder to the left knee. Right shoulder to the left knee. So, my question is, what muscles are tested here? Because you might be asked, muscles are tested. There are two muscles that are being tested here. We call that one your obliques. Oblique muscles. Okay, so, however, you have two obliques. External oblique and internal oblique. Okay, oblique muscles. They're called oblique because they're oblique. So it's like this, right? Their muscle fibers are positioned this way. They're not straight, they're like diagonal, oblique. So in this case, if you're asked, what muscle is being tested? If you're trying to lift your right shoulder or move your right shoulder towards your left knee. So, just imagine, if you fully move your knees again, if you fully flex your knee right here, so if you flex your knee towards here, they approximate, right, your shoulder and your knees. And they tend to cover here the left side. If you can imagine it, when they approximate, meaning nag-abot ang imong knees o elbow, they're trying to cover the left side. Since this is how I familiarize the obliques in terms of their action. So this is turning or rotating towards the left. Okay, towards the left side. So if we rotate towards the left side, we are covering the left side if the knees and the elbows are to approximate each other. Since they are covering the left side, the muscles that are beneath it, this is how I familiarize this one. So you can also use this concept. So since the left side is being covered, the muscles that are acting here is your left internal oblique and right external oblique. Okay, so this is the concept here. Whatever is the rotation, the direction of rotation, the left internal oblique is contracting. So in this case, if it's on the left rotation, left internal oblique and right external oblique. So if the opposite is happening, the left shoulder towards the right knee, so the left shoulder is towards the right knee, that's actually rotating towards the right side. So there is one. Right internal oblique contraction as well as left external oblique contraction. So that's the concept here. So I hope you can use this concept in your assessment later on as well as during your examinations. Okay, written examinations. Okay, next. Okay, it's here. Note, right elbow to left knee, right external obliques and left internal oblique. Right elbow to left knee, turning towards the left side. Okay, so trunk rotation grade 4. Position of the patient crossed over the chest as usual to decrease the resistance by moving it closer to the center of gravity. Test other than the patient's position, same aspect of the test for grade 5. Okay, so still instruction of the patient is the same. Moving, facing up, trying to turn towards here, it activates the left internal and right external obliques. And the opposite is also true. So for grade 3, position of the patient, supine with arms outstretched above the plane of the body. Okay, test position of therapist and instructions are the same for grade 5. The test is done first to the left and then to the right. Okay, so like this, as if you're trying to move, getting up from bed. Okay. Your instruction to the patient is lift your head and shoulders from the table, taking your right elbow towards your left knee. Then lift your head and shoulders from the table, taking your left elbow towards your right knee. So that's it for your other side. So for rotation, grade 2, supine with arms outstretched above plane of the body, it's still the same. Standing at the level of the patient's waist, therapist palpates the external oblique first on one side and then the other, with one hand placed on the lateral aspect of the anterior abdominal wall distal to the rib cage. I have a picture here. Test. Patient attempts to raise the body and turn towards the right. So it's like this. You're palpating the muscles here on the abdominal region, and then the instruction is lift your head and reach toward your right knee. Okay, then palpation, there's palpable contraction and movement, partial movement. For grade 1, it's like this. Supine with arms at the sides. Flex the hip, feet flat, although the feet cannot be seen in the picture here. Then the head is supported as patient attempts to turn to one side. This is again, you're like cradling the patient's head. This is to facilitate if you cannot really feel the contraction. Okay. Patient attempts to flex the trunk and turn to either side. Then instruction, try to lift and turn to your right. So then to your left as well to complete the test. Then this is the end of my lecture, and the LOs that we have achieved are this. The students are now able to ask pertinent questions relevant to the patient's history, apply the concept of the plumb line upon observation on the different segments of the spine, theoretically measure the range of motion of the different spinal segments with the use of goniometer and tape measure, whichever is applicable, assess the muscle strength of each segment of the spine, apply clinical decision making in referring patients to appropriate health professional, and lastly, create a hypothetical intervention using the concept of upper and lower cross syndrome. Thank you for listening.